Hello friends, myself Dr. Mohammad Rafiullah. I am going to discuss about the management of COVID-19 in children. So basically, what are the clinical features of COVID-19 in children? What majority of children with COVID infection may be they may be asymptomatic or mildly symptomatic. What are the common symptoms which they have is fever, cough, breathlessness, shortness of breath, fatigue may be there, myalgia may be there may be rhinorrhea, there may be throat irritation, that means sore throat, diarrhea, loss of smell and loss of taste may be there. Few children may present with gastrointestinal symptoms with atypical symptoms. A new syndrome has come which is also known as multisystem inflammatory syndrome, which we will study later. Now, what is asymptomatic and mild case? Asymptomatic children are usually identified while screening. If family members are identified, they require monitoring for development of symptoms, in what time symptoms develop, whether symptoms will develop or not, and subsequent treatment according to the assessed severity of the patient. That means mild, moderate and severe. Children with mild disease may present with sore throat, rhinorrhea, cough with no breathing difficulty. Few children may have gastrointestinal symptoms. They do not need any investigation for such features. These children can be managed at home with home isolation and symptomatic treatment. Okay, so the children with underlying comorbid conditions, many children have underlying comorbid conditions including congenital heart disease, chronic lung disease, chronic organ dysfunctions like those who need renal replacement therapy or obesity may also be managed at home. Now, there is no role of hydroxychloroquine or favipiravir or ivermectin or remdesivir or immunomodulators including tocilizumab, which is in use nowadays, or interferon beta 1a, or convalescent plasma transfusion or dexamethasone in such mild cases. You have to maintain monitoring chart including count of respiratory rate 2 to 3 times per day, okay. Look for the chest in drawing. Bluish discoloration of the body should be looked for. Cold extremities, urine output, very important. Oxygen saturation should be looked for. They should be looked for 2 to 3 times per day. Fluid intake and activity levels should be looked for, whether the patient is lethargic or the activity level is less, especially in young children. The parents or caregivers to contact the doctor in case of any emergency or any deterioration of the severity. What is moderate case? Moderate case in case of COVID-19 children is characterized by if he or she has the following: rapid respiratory rate, this is age based and this is as follows: respiratory rate of more than equal to 60 for less than 2 months. If they are 2 to 12 months of age, respiratory rate of more than 50 will be categorized as moderate COVID-19 case. If respiratory rate is more than 40 for 1 to 5 years of age, and for more than 5 years of age, respiratory rate is more than 30, and oxygen saturation, all these groups to be above 90%. This is very important. Child may be suffering from pneumonia which may not be clinically present. What are the investigation? At present, in moderate case, no lab tests are required routinely unless indicated by any associated comorbid condition which is discussed before. Treatment is to be admitted to dedicated COVID health center, DCHC, or secondary level healthcare facility, and monitored for clinical progress. We have to maintain the fluid and electrolyte balance. We have to encourage oral feeds. Breast feeds should be encouraged in infants. If oral intake is poor, intravenous fluid therapy should be initiated as early as possible. Okay, now the child in moderate cases, what should be given to the child? This is very important. For fever, you have to give paracetamol 10 to 15 mg per kg per dose. It may be repeated every 4 to 6 hours. If the temperature is more than 38 degrees centigrade, that is in Fahrenheit 100.4 degree Fahrenheit. In antibiotics, amoxicillin to be administered. Okay, if there is evidence or a strong suspicion of bacterial infection, then amoxicillin should be given. If SpO2 is below 94%, oxygen supplementation is required, it's mandatory. Corticosteroids may be administered in rapidly progressive disease if the progression is very rapid, not required in all children with moderate illness, but if there is rapid progression, then corticosteroids should be given. Especially in first few days, this is not required. Supportive cares for the comorbid condition, if any, like obesity, chronic lung disease, or the patient requiring renal replacement therapy should be given. What is severe COVID-19 case? So the children with SpO2 level less than 90% are characterized as having severe COVID-19 infection. They may have severe pneumonia, acute respiratory distress syndrome, septic shock, multi-organ dysfunction syndrome, or pneumonia with cyanosis. Clinically, such children may present with grunting, severe retraction of chest, lethargy, somnolence, seizure. Such children should be admitted to the dedicated COVID hospital, secondary or tertiary level healthcare facility. Few children may require HDU, that is high dependency unit, or ICU, that is intensive care unit care, and should be assessed for thrombocytosis and organ failure. Okay. What are the investigations required in such cases? The complete blood count, liver and renal function test, and chest X-ray should be done in such severe cases. What is the treatment? Treatment is intravenous fluid therapy. Fluid therapy is very important in such patients. Corticosteroids should be started, that is dexamethasone 0.15 mg per kg per dose, maximum 6 mg should be given twice a day. Maximum 6 mg in a day should be given. Equivalent dose of methylprednisolone may be required for 5 to 14 days depending on the clinical assessment. What should be the antiviral drug which should be given? Remdesivir, granted for emergency use authorization to be used in a restricted manner within 3 days of onset of the symptoms, after ascertaining that child's renal and liver function tests are normal, and to be monitored for side effects is very important. The liver and renal function should be normal for the child who is to be administered remdesivir. Suggested doses are body weight best more than 40 kg, 200 mg on first day, then 100 mg once daily for 4 days. What is the if the body weight is 3.5 to 4 kgs, 5 mg per kg for the first day, and then 2.5 mg per kg once daily for 4 days. There is no role of hydroxychloroquine, favipiravir, ivermectin, lopinavir, ritonavir, umifenovir. Okay. These children may need organ support in case of organ dysfunction like renal replacement therapy. What is the protocols for management and treatment of acute respiratory distress syndrome in such patient? If the patient is having mild ARDS, then high flow nasal oxygenation should be given. Non-invasive ventilation, if the patient is compliant, then it can be considered. If severe ARDS develops, mechanical ventilation may be given to low tidal volume. That is the strategy in ARDS, low tidal volume. If the child does not improve clinically, even then you may consider high frequency oscillatory ventilation, which is not available in every center. It is available in high-end center only, or extracorporeal membrane oxygenation, which is also in a short form as ECMO. Awake proning may be considered in older hypoxemic children if they tolerate. So in severe COVID-19 cases, if the child develops septic shock or myocardial dysfunction, then he or she may require crystalloid bolus administration, that is 10 to 20 ml per kg over 30 to 60 minutes, and be cautious if cardiac dysfunction is there. Early inotropic support with monitoring of fluid overload like any other case of shock. Okay. So one thing, it is very common, it is in news that MIS, multi-system inflammatory syndrome, is develops in patients with severe COVID-19, in children with severe COVID-19. What is MIS? MIS criteria is children and adolescents 0 to 19 years of age with fever more than 3 days and any two of these: rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs, hypotension or shock, rash or bilateral, and evidence of coagulopathy by PT, APTT, elevated D dimers, and acute gastrointestinal problems like diarrhea, vomiting, and abdominal pain, and elevated markers of inflammation such as ESR, C-reactive protein, or procalcitonin, and no other obvious microbial cause of inflammation, including bacterial sepsis or staphylococcal or streptococcal shock syndrome, and evidence of COVID-19 positivity by RT-PCR antigen test or serology positive, or likely contact with patients with COVID-19 in close proximity. Investigation which we can order is CBC, ESR, C-reactive protein, procalcitonin, LDH, and D dimer. What drug is to be given in MIS? It is very important. Drug to be used in case of if the child has cardiac dysfunction, shock, or coronary syndrome, multi-organ dysfunction, is steroid methylprednisolone should be given, that is 1 to 2 mg per kg per day. Intravenous immunoglobulin is given 2 gram per kg over 24 to 48 hours, and with all these, antimicrobials should be started. The child needs appropriate supportive care, preferably in ICU. Okay, in absence of cardiac dysfunction, shock, coronary involvement, multi-organ dysfunction, one may use steroids or IVIG. If the children doesn't improve with above treatment or deteriorates, options should include repeat IVIG, that is intravenous immunoglobulin, high dose of corticosteroids, that is methylprednisolone, 10 to 30 mg per kg for 3 to 5 days. Aspirin should be given 3 mg per kg per day to 5 mg per kg per day, maximum 81 mg per kg if thrombosis or coronary aneurysm score is more than 2.5. Low molecular weight heparin, that is enoxaparin, should be given, that is 1 mg per kg twice daily subcutaneously. Steroids have to be tapered over 2 to 3 weeks while monitoring inflammatory markers. Inflammatory markers should always be monitored while tapering steroids. For children with cardiac involvement, repeat ECG 48 hourly, okay, and repeat echo at 7 to 14 days and between 4 to 6 weeks, and after 1 year of initial echo was abnormal. One thing very important which we should emphasize is many people ask this question: can I stop wearing my mask and taking precautions after I have got vaccinated? No, you should not. You should always wear a mask. You must continue to practice precaution because it takes time to complete protection even if you are vaccinated. It takes 2 weeks after the second dose of the vaccine for antibodies to start developing, and if there are any cases of infection after vaccination, the infection would be mild and not dangerous. Continue to practice all precautions so that you do not get infected or spread infection to others. What should you do is you should wear a mask, you should wash your hands frequently, you should use sanitizer for hand hygiene, you should maintain physical distancing for at least 6 feet, that is 2 meters. Avoid crowds by not going to malls or cinema halls or in crowded places. You should get the vaccine today. Your tomorrow will be better for you. Thank you very much.